Dear audience, I would like to point out that the success of such a meeting is not based on the presentations alone, but also on critical discussions and debates.
My name is Thomas Kipsker and I'm going to talk to you about sacral joint and what do we know and not know in the diagnosis and treatment. But if we have a poor result, one might say that we have missed the target, that actually the SI joint pain exists, and we are not able to diagnose it correctly. Because the real-time effectiveness of these types of treatments is the variability is, I think, because of people doing it wrong.
Welcome to this third talk of the ICSJS 2021. The sacroiliac joint is a highly complex and combined joint.
That this ligament is so densely connected to the surrounding muscular structures.
My name is Carolina Schadek. I'm an anesthesiologist and pain physician at the Amsterdam University Medical Center. Furthermore, receptors classified as mechanoreceptors type 2 were found in anterior SI ligament.
There's no MRI correlation for the sciatic pain or for foraminal stenosis or something.
We do this diagnostic block on a piriformis. We start with it, and if it helps, we do the Botox infiltration, and then we treat the sacroiliac joint.
What are the characteristics and abilities of a sacroiliac joint? I have studied sacroiliac joint biomechanics for more than 30 years, and I will try to implement the current knowledge. Usually, I teach that the function we expect from the sacroiliac joint is to transfer load from the spine out to each leg. If you restore the muscle function, then you will have a good function also in the sacroiliac joint.
So can this articulation be painful? We see that here the lumbar lordosis was decreasing and the pelvis start to back tilt, always to try to keep the equilibrium. The high pelvic incidence patients have more sacroiliac joint shear forces because they have more ability to retrovert.
So what is the mechanism of the pain in the circumstances of malalignment?
The mechanism, there are many mechanisms, I think, that because it's not only the sacroiliac joint pain.
I'm glad to have an opportunity to share with you our experiences regarding SIJ injections. How many surgeons would choose to be operated on or to have a family member be operated on for SIJ pain? Started with periarticular injection. The effectiveness rate was 81%. Here we will research the SIJ biomechanics using the Android robot, which has the SIJ structures. Thank you for your attention.
What were your reasons to say the cutoff is 70%?
We use pain relief scale to evaluate the injection efficacy. The pain before injection is assumed to be 10.
I'm Shannon Roberts, and today I'll be presenting on denervation of the SIJ. There's variation in the number and location of the lateral branches as they emerge from the posterior sacral foramina. Conventional multi-electrode and cooled monopolar. For the Palisade technique, 5 to 7 needles are placed 10 millimeters apart along a straight line just lateral to the strategies to optimize clinical outcomes include, most importantly, the use of valid diagnostic blocks.
Yes, they would be anesthetizing the anterior capsule, and that should not be done.
Listen to Ibrahim here. He talks about the durability of this technique.
My name is Kai Hermann and I'm a radiologist from Berlin. In certain circumstances, oblique views are performed, for instance the Ferguson view. It may be difficult to find these lesions on an AP X-ray. Newer devices are also able to perform dual energy CT, and this allows for depiction of lesions within the bone marrow, like bone marrow edema or other lesions. On the T1 weighted sequence, we are searching for structural damage, and on the STIR sequence, we are searching for the active inflammatory processes.
I have another question, because you have a lot of experience about inflammatory diseases like ankylosing spondylitis.
Natural fusion of the sacroiliac joint in AS patients is only occurring if the patients are neglecting the disease and are refusing visiting a doctor.
You ask me whether registries are still a challenge, and in case you were convinced and tried to participate in a registry, the settings in your hospital, like IT, were so bad and your staff so reluctant that plenty gave up. There's an explosion of activity at various levels, like medical societies. In Europe, one could invent a device, put a CE certification on it, and then implant it in thousands or 100,000s of patients without any need of control.
The implants for SI joint, especially these implants, have to be put in a registry. So I really glad that you are interested in registries and that you try to put in the data out of your society. And I'm really looking forward for the next presentation.
The SI joint registry. What is ESAR? The most important aim is to get a tool to follow our patients, measure our results, and to improve our questionnaires. This is an example of one way it could go. So you see the patient in a consultation decide that he should be on the registry. The patient agrees, and so we start the patient in ESAR with conservative treatment. You assign the patient to this type of therapy.
Your protocol is more complicated. I am afraid it will take too much time.
But that we get some doctors who work with it, and then we see what is necessary, what is missing, and what is too much. And then it's always easy to take out some questions and to reduce the questions and see how it works.
Dear Volker, dear colleagues, thank you for letting me talk about techniques, pitfalls, and revision strategies. And if needed, for such cases, navigation comes in quite handy. The company provides a special explantation kit because you actually cut out the implant from the ileum.
And you fill up the holes with bone or something? Or
actually, nothing.
That
no.
You have, but
no.
Do you recommend navigation for
only the tricky cases? I agree. I don't recommend for the beginning. The surgery is not that complicated. You are able to hit the target.
We are trying to compare transgluteal approach with posterior oblique approach. Again, if the pain get better, more than 70%, basically, we proceed with surgical intervention. Based on that picture, you see this patient got a pseudoarthrosis and a halo around the impacted implant.
Posterior lateral approach did better in your hands than those with a lateral approach.
The reason in my mind is related to the trauma to the muscles, basically, because with posterior oblique approach, honestly, we don't cut any muscle, we don't make any trauma to the muscle.
To review, SI fusion has several options, including the straight lateral approach, the posterolateral approach, the straight posterior approach, the posterior medial approach, which is our area, and related posterior medial approaches. Treatment of osteoarthritis should follow orthopedic principles. Here you see parasagittal films of the sacroiliac joint going from normal to a severely degenerative osteoarthritic joint. And I would point out there's no orthopedic procedure elsewhere in the body where painful degenerative surfaces are forced together and expected to heal.
If it's too complicated, then it's quite risky. In your hands, no problem, but in our hands, what do you think?
Yeah, it's very definitely, the Diana especially was very technique dependent. And the recess is an operation in itself that had to be cleaned out, prepared, and bone grafted.
Today I'll be presenting on the technique, pitfalls, and revision strategies using the posterior-inferior approach. And you can see this required some rigid fixation, but over time we were able to narrowed down this approach just to the posterior inferior portion of the. And again, this approach is very helpful for diagnosing pain despite internal fixation with fixating devices, non-fusion devices.
They got their own belief system and training programs, and a lot of industry is backing up their ideas. So we'll see where it goes. We'll see where it goes.
See where it goes. Yes, that's a good question.
I'm the unusual guy here in the setting, right? I'm doing some SI fusions, but I see there's a lot of experience, but especially in the elderly, it's sometimes really difficult to see it. So to really have the best of all ideas, if it's good enough or not. And we have to look at the quality of fusion, how to prove that. Is it only no motion? How to prove no motion in the SI joint? You can only do it indirectly. Or do we rely on a real CT scan with bony bridges from the ilium to the sacrum? Fixation points should be enough, because the other problem is, which we didn't talk about, is those sacral fractures after those longer fusion, which we see in an increasing number, probably in the US as well. That's especially in those occult osteoporotics.
I'm Dr. David Pauly from the University of Minnesota. For sacroiliac fusion in clinical trials, we see the first publication about 2000, and over the last 5 to 10 years, significant increase in the publication rate. There was a pooled analysis performed of 3 of the iFuse device studies. They had similar inclusion criteria and similar outcome metrics, which made this pooled analysis possible. There is prospective multi-center cohort data available for the iFuse triangular titanium rod, the Diana threaded cage, and the Symmetry screw devices.
How come they were the fastest to get the RCTs internationally going? And how much of an unfair advantage may this be in the current evidence situation?
Yeah, so clearly RCTs and high-level studies cost a lot of money. And so that requires a company that can and will make the investment in evidence generation. And that's the challenge.
Field. And granted, this could go in a lot of different directions. And this is sort of what caught my fancy as I was listening to all the talks. So one of the themes that it is important from the surgical point of view is SI joint surgery just for those of us crazy enough to actually care about it? Or is it something every surgeon in the world needs to understand? And as David Pauly has said, it's okay to ignore the SI joint if you don't mind being wrong 20% of the time going forward, but we need as much knowledge to make these complex decisions as we can get. So I'd like to thank Volker Fuchs and Michael Dirks for their tremendous amount of work organizing this meeting, for all the speakers for their expert contributions, our sponsors for their support, and importantly, I'd like to thank everybody that has chosen to participate in SIMEG. We really need everybody's participation and the growth of the society and the growth of the spine surgery world's understanding of SI joint disease. Thank you.
Been an honor to be elected the next president of the society. I've been involved in this for almost my entire career, and obviously people who were around at that period of time know we were pariahs. Anybody believed in this or even thought about doing a surgical procedure, oh my God, tarred and feathered. I mean, it was crazy.